Hi, I'm Valerie Phelps with the International Academy of Orthopedic Medicine. You've heard my lecture on ischemia reperfusion, which is quite extensive, and now I would just like to summarize that for you in a few slides. First of all, why do you need to know something about ischemic reperfusion? Well, it's important to realize that there's an injury that is beyond the scalpel in most surgeries. And what we also saw was that there are similar injuries to the ischemia reperfusion that we want to take into context when we're working with various patients. Why do you need to know it? Awareness of ischemia reperfusion guides us in pacing our patients, in understanding their ongoing weakness, for instance, and in choosing the best techniques for optimal patient outcomes. What do you need to do? Well, we have options for our patients in prehab. We're going to teach our patients self-care strategies to control swelling. In early rehab, we're going to be able to perform techniques to reduce swelling. That is our key, if you remember, and what you're going to see in the pictures ahead. We want to minimize the growth of aphysiological crosslinks and myofascial adhesions in the surgical limb or the affected limb, and we want to pace our patient to allow for their system to regain its integrity after the ischemia reperfusion injury, as well as to allow for nerve healing. In late rehab, we're going to want to utilize deeper soft tissue techniques to reduce the intra and intermuscular adhesions. And I'll be showing how to do that, or how I do that, at the end of this lecture. Why do we want to do it? Well, because we're complete clinicians. We understand the depth of this kind of injury and what's related to surgery. Our knowledge allows for precision in clinical practice. In our care, it allows for reassuring our patients, as you're going to see when I'm working with my patient at the end of the lecture, and it will lead to the best clinical outcomes. And in order for you to keep some of this in mind, I'm going to give you some pictures that I really want you just to look at as I talk about them. That's what I want you to ingrain in your mind. And I have a few handouts for you. So a reminder, in ischemia reperfusion, it is the tissue damage that occurs during restoration of blood flow that's actually significantly greater than that which occurs during the ischemic event. And when is that going to happen? Basically, following a tourniquet application during surgery, orthopedic surgeries generally, but really we're going to see that it occurs after almost any compressive event. We're going to look at some of that related to our patients, but as I mentioned in my lecture, they've seen it in neurosurgery and heart attack situations as well. Let's go back just a moment. I want you to keep in your mind this picture. This is a control group of normal muscle tissue, and this is post and ischemia reperfusion injury. This is 2 hours after the injury, and this is 3 hours after the injury. And by injury, I mean this is 3 hours after reperfusion. So on a close-up, what we're going to see is disruption of muscle fibers. In a longitudinal section, you see these multiple points of disruption, and then you see microedema between the fibers, and that is compared to normal muscle tissue. On a cross-section, they see that injury is observed within patches of a given muscle, so kind of random, and that's what we're going to look for when we palpate our patients. Here is an ischemic reperfusion injury with compression. So what happens when we have ischemia with compression? Well, what they see is that fibrotic scar tissue formation is going to be enhanced. So here again, just look at the picture. This is an uninvolved limb. This is an ischemic reperfusion. Look at the increase in space between some of the cells. This is a compressive injury only. And then this is ischemic with compression. So again, we see muscle fiber breaches, and we see increased space and increased fibrosis. So in a surgical limb, is there any compression? Think about it. There may be a tourniquet. There may be where the holders are holding the tissue apart in order for the surgeon to get in, and there may be a limb holder. So we'll be looking at that in the slides ahead. Compression is going to add fibrosis, but so will oxidative stress. If an ischemic or a hypoxic condition occurs or exists before the injury, there will be a poor muscle regeneration and enhanced scar formation. What conditions are that? For instance, an athlete who is under oxidative stress in the fatigue part of whatever activity they're doing, and also in the aged patient or aged athlete. So here we have control, and again, I want you to take a look and put this in your mind of fibrosis that has occurred in a healing process of ischemic muscles. This is what I want you to envision when you're working and doing soft tissue mobilization with your patients. Now we have age and immobilization. How does that affect muscle tissue? Well, they see that it affects the inflammatory response, the revascularization is going to be compromised, and the myogenic and growth factors are inhibited as well. Here is a young limb and an old limb, and you can see that adding exercise after cast removal actually makes fibrosis in the older patient worse. So I was talking about this with one of my residents this week, and he said, so what do we do? And I said, well, the funny thing about researchers is they do the research, but they don't always give clinical application. That's up to us and our clinical expertise to decide. But I would encourage you to be very careful when an elder patient comes out of an immobilization device or begins to move after surgery. Think first about reducing inflammation. Think about the ischemia reperfusion. Think about the microedema between cells. Think about the muscle fiber breaches. And if you can first get rid of that inflammation, we're going to have, I think, far less fibrous tissue lay down. And then also related to, I think, any kind of surgery is this deep tissue injury. It is a differential diagnosis with similar and interwoven pathology to the ischemia reperfusion. But here what they see is tissue damage that starts in deep tissues underneath intact skin. This is not intact, but you know in my lecture we have a broader story about that. But what it takes is partial ischemic position or condition, and with some deformation. So imagine a limb holder, or here we looked at this, a limb holder or a kind of a device around the leg, and if it's not tight and there's a little bit of jiggle to it, you can get some deeper tissue damage. And I have a couple of other cases for you. A 63-year-old client of mine post-total knee came out of the total knee with a sural neuropathy, significant hyperesthesia, and a bruised and broken toe. So I doubt that that was a deep, that the bruised and broken toe was a deep tissue injury, but the sural neuropathy surely could have been. And we have the current case of the young man that I'm going to be working with, although I think he's about 51, he's younger than me. He came out with localized severe bruising at the medial heel, and he had bruising along the entire medial aspect of the shin. So what we want to ask ourselves is, tell me about the tourniquet time and the location of the tourniquet. I want to certainly look at tissue in that area. What did the limb holder look like? I'd like to talk to the surgeon. What are you using? Are you using this device or that device? But you can see if a patient who had their lower leg in a device like this surely could have a compressive ischemic deformation. So expect to see potentially calf and or even perineal muscle fiber damage deep to the tissue as a result of the surgery. And then ask, has there been a period of immobilization? Think about that fibrosis tendency in those patients. So what I want you to keep in mind in general, there is a systemic inflammation in your patient. Pace them slowly to their return to exercise and activity. In the surgical limb, there may be a local neuropathy due to the compressive event and the reperfusion. There will be muscle fiber disruption, and there will be that intercellular edema. In the immobilized limb, or if there was a pre-injury oxidative stress, so the gentleman that I'm going to present to you had a very, very active day of skiing before his injury. He likely got injured in part due to fatigue. And so that's going to make his response a little bit slower and potentially the myofascial structures a little bit more fibrotic. And or is it an aged limb? And age is not given to us specifically what the cutoff is, but we know that with every decade after about the age of 30, our healing times are slower. So if we have somebody who's in their early 50s, they might be certainly leaning towards that aged limb. Be aware of that increased fibrosis during healing of the entire limb. And remember, the structural integrity of the muscle can affect its activation and blood supply. So strengthening too soon may actually make it worse. In the early stages of rehab, get rid of swelling, regain mobility, restore myofascial integrity, and then progress your exercises on top of that. Of course, people should be exercising early on, but how vigorously? That's the question. And have you, as the provider, ensured optimal muscle integrity? So some treatment considerations are to enhance circulation in the healing limb and to raise pain thresholds, which is going to decrease the pain experience. Consider doing some kind of sympathetic dampening, either by modality or manual therapy, and it will enhance any nerve healing as well. In the acute patient, be patient with muscle activation and vigorous exercise early on. I like to activate, and then once the parameters of good muscle tissue have been met, begin to be a little bit more aggressive with your strengthening and your endurance exercises. Be sure to restore lymphatic flow by manual lymphatic drainage, starting at the neck and then working on the affected limb. And after 6 weeks, and I would say even as early as 3 weeks, we can begin a little bit more aggressive about breaking up any aphysiological crosslinks and scar tissue through our press and stretch, transverse and longitudinal techniques. And maybe add this to your post-surgical protocol. I found this protocol online by the Stone Clinic in California, and one thing stood out for me that I thought was magnificent, and that is week 1, they talk about manual therapy. Start soft tissue treatments to include gentle mobilization of the posterior musculature. All of us do patellar and incisional mobilizations, but surely begin to do more entire limb techniques to the posterior, or I'll say the non-surgical aspect of the limb that you're working with. And I'll show you how to do that at the end of this lecture. And what I'm going to show you is also provided for you in a handout, so you can follow along when you're watching. And what I'm going to show is how both the individual and the therapist can perform what I call manual lymphatic drainage. It's a take on manual lymphatic drainage that seems to work really well for swelling control. And then I'm going to show you the kind of press and stretch techniques that I do for myofascial adhesions, both throughout the limb, in the zones of tourniquet application, maybe where the limb holder was, and then closer to the joint itself. I hope you enjoy. I've spoken intensively about the ischemia reperfusion injury, and what I'd like to show you now are a few techniques that you can use for both prehab as well as rehab that will help to mitigate that swelling that I'm talking about and will help to move the swelling and some of the inflammation out so that you have a more optimal healing of the muscle. The first technique I'm going to show you is one that both you and your patient can do, and I've provided a handout for you to follow along. Think about this technique as doing it in 3s and 5s. And basically, at the level of the neck, you're going to simply be moving the skin over the tissue underneath. So I'm going to place my hands on the patient's neck just below the mastoid. And basically, I'm going to follow the sternocleidomastoid down, and I'm going to finish with what I call a sort of a breaststroke technique in the supraclavicular fossa region. Now, this is a take on manual lymphatic drainage, but it really is something that I've developed in the clinic that gives excellent results. If you want to really learn manual lymphatic drainage, please go to a dedicated school. Again, we're going to start just below the mastoid, and we're going to divide this technique in 3 different zones within the same region. Each time I place my hands, I'm going to do 5 half circles backwards. So, spot 1 under the mastoid, spot 2 mid sternocleidomastoid muscle, and spot 3 is going to be above the supraclavicular fossa. Good. Okay, so 1, 2, and 3. And that's done a total of 3 repetitions. You and your patient can end with what are called long strokes from the mastoid process along the sternocleidomastoid to the sternal region. Now, if the patient's going to do it themselves, and you can try it on yourself, I like a kind of a crossed hand approach. So here I go, crossed hands, 3 half circles going backwards just below the mastoid, a new spot midway, about mid sternocleidomastoid muscle level, and then I do my back strokes in my supraclavicular fossa region, again, about 5 repetitions. And this is repeated 3 times. So when this is performed, it enhances the lymphatic flow throughout the entire region. And in cases of surgery, the lymphatics tend to get sluggish or stop completely as a result of the injury that occurs with surgery, and also due to excessive icing sometimes afterwards. So the patient can start this technique at home before surgery, and they should do it at least twice a day right after surgery. From the neck, we're going to move down to the leg. And the technique that I'm going to show you now is much more easily done by a different person. However, this particular patient was able to follow through with the home program, and as you can see, has done a magnificent job of managing swelling in this barely 3-week post-ACL surgical knee. So what we're going to recommend is that you and or a partner or spouse at home start this soft tissue technique in the region of the tourniquet. So that's going to be in the upper leg area. And what we're going to do is we're going to take thigh, knee, and lower leg, again, divided into 3 regions, and perform 5 semicircles on each. Now, right after surgery, you really want to avoid the surgical site. So we're going to demonstrate this primarily with pressure at the posterior aspect of the leg. So what we recommend is that the individual take 2 hands, go on either side of the top of the leg, and if you're uncomfortable going in the groin region, then at least go to the flexor region of the hip and the hamstring gluteal junction and perform 3 to 5 nice big semicircles on either side of the IT band. From there, go mid-thigh and again 3 strokes, or I should say 5 strokes. And again, lower leg, these half circle, and then at the knee, we're going to divide the knee into 3 as well. So half circles, staying behind in acute post-surgical days, then mid posterior knee, and then the lower posterior knee. Then we'll follow with the lower leg. And further down, mid-leg, and finally the distal part of the lower leg. And the entire process is repeated 3 times. When you're done, perform here 2 long strokes from the ankle to the groin and gluteal region. We'll do 3 of those to finish the procedure. As the healing process continues, and if the patient can tolerate, for instance, we're working with the lower extremity here, but if the individual can tolerate, and let me know how this feels, for a little bit of support under the lower leg area, then we can work on gaining our terminal extension as well as performing our swelling drainage technique. And to do that, we can go a little bit deeper, particularly if you've noticed that there might be any pitting edema, or you're just really wanting to move out some of the swelling. Take some massage cream or some lotion, and here you can glide a little bit more vigorously, though not too vigorously, over the soft tissue structures. And this technique is best done in the 2nd and 3rd weeks and beyond. And again, you see I'm marking off 3 zones and repeating 5 semicircle movements at each level. A little bit more aggressive, but still very comfortable for the patient and very much moving the swelling out. Again, 3s and 5s. Divide each area into 3 regions. And here I'll go on the side. Five repetitions, 3 times, 3 sets, and then finish up here. Now we've got a little bit of lotion on the leg. We can be even a little bit more aggressive with pushing the swelling out. And if this can be performed regularly within the first 2 weeks, you're going to see a drastic reduction in swelling. From the leg, we go back to the neck and we repeat our techniques just as we started. Okay, we do this 3 times, then 5 long strokes. About 3 weeks after surgery, and certainly after 6 weeks, we're going to want to look for and treat any adhesions or deep scarring that might have occurred in the limb as a result of changes and muscle damage that will happen under any compressed zones in the leg, and then also look for any areas where we've had that muscle fiber disruption. So I'll always start at the tourniquet site because I feel that sometimes the tourniquet actually, though it's not on the leg, changes in the muscle have occurred that will almost create an internal congestion. And we want to open that area, improve the blood flow and the lymphatic flow so that swelling, all of the residual swelling, can move out of the leg. And in particular, when you have a patient post-knee arthroscopy or post-total knee replacement, and they come to you with persistent swelling, even up to years later, go look at that tourniquet site. It's highly likely that they have this internal physical tourniquet type effect going on. And if you can work on that and loosen that tissue up, then the swelling has a chance to move out. It's been my clinical experience also that when I work in the area where the tourniquet is, that can actually, for some reason, even help gain some of our last degrees of range of motion. Go figure, but the myofascial system has so much to offer us. So again, I'm going to be doing deeper work. I'm going to take massage cream, and now I'm going to go in deeply. I'm going to watch my patient's face because here I am going deeply. I want to stretch fascia. I want to look for any fibrous bands. I want to look for thickness in the tissue. And sometimes, of course, I know we've got the femoral nerve here, but sometimes you'll feel kind of a bogginess. And that bogginess is congealed, either brawny edema or pitting edema, or even just a change in the subcutaneous tissue. So do long strokes, feel for a change in tissue integrity, and mostly I work transverse to the structure that I'm trying to work on, at least initially. So big long strokes, and then what I will do is systematically go through every muscle because we saw that those, yes, there we go, we saw that those fiber disruptions occur randomly, mostly throughout muscle bellies in the affected limb. So here we find some fibrous changes already just at 3 weeks. It's a little tender for our patient who's trying to keep a smile, but okay, we back off to make it tolerable. And once I find some of these fibrous adhesions, I'm going to start a transverse press and stretch kind of technique, and I'm going to watch the clock. I can get the biggest bang for my buck at about 2 to 3 minutes. So the connective tissue is going to give the most within the first 2 to 3 minutes. That's kind of the hysteresis effect. So I will do that. And then after 2 to 3 minutes, I'm going to do a longitudinal stroke. Kind of move any swelling or microedema. Remember the pictures I showed you, that microedema between every muscle fiber. Oh, very nice. Okay, good. And then I will go after a different muscle. So here, lateral quad, yes, another spot. Remember, the ischemia reperfusion injury occurs throughout the entire limb. So it's not selective to the muscle. And if you look how far above the knee I actually am, don't just focus your techniques at the local surgical site. Move and check the entire limb. Okay, so let's say I've done that for 3 minutes, then up we go. Good. And I might come now to the medial aspect. Yes. Yes, right there. Again, feel a nice fibrous band, a little thickening. Yep. In the medial quadriceps. And again, 2 to 3 minutes. And if you can do this now 3 weeks post-surgery versus 3 months post-surgery, or even 3 years post-surgery, you're going to have such better effects. The connective tissue here is now very, very weak in the first 6 weeks. It begins to strengthen in the second 6 weeks, and of course by a year it's going to be pretty solid, but still responsive, although it will take much longer to work through. So as you can see, I'm going transverse, I'm going longitudinal, and although I'm treating this young man in supine, the next time we see each other, I would put him in side lying and treat both the hamstrings and the region of the IT band as well. So going lower, now, a lot of times we wouldn't even imagine that there's something going on in the calf, but yes, you get a little nod, little smile. So here, lateral gastroc, again, press and stretch, push and move through the fibrous tissue that you feel. 3 minutes, and then move up, longitudinal, and go down. And I know in particular we have something in the perineals, although I worked on that last time, so it's even better. It's better today. Yeah. Good. We'll find some new spots. All right. So that is the press and stretch technique that is going to be very, very effective in working with those muscle fiber tears throughout the limb. And then, of course, you are very aware of how to work in and around the knee to reduce the local swelling there. Okay. Yeah, good. When you're working with swelling around a joint, there are a couple of things to consider. There's going to be superficial swelling that we are going to use light strokes to reduce and move up more towards the heart. But the longer the swelling stays in and around the joint, particularly the concavities around a joint, the greater the tendency for that swelling to thicken. And if there has been surgery done in a joint, we always are going to have that concern of something called arthrofibrosis. So arthrofibrosis is when blood is left behind in the joint, and blood in a joint creates really massive adhesions. So in and around the knee, for instance, everybody is very, very familiar with scar mobilization, and we teach that to our patients. But in and around the knee, I think that we can do a little bit deeper work. This is 3 weeks post-surgery, so I'm able to get in, and I like to imagine the swelling in this case to be similar to pushing Jell-O out of a sponge. I want you to remember the pictures of the swelling between pretty much every cell, and while I'm avoiding the incision sites, I'm definitely just going to be doing a very local, pretty firm pressure to move this swelling as best as I can through and out the joint. And don't forget, in the knee area, there's a posterior recess as well. In the popliteal fossa, we can really get some thickened swelling in that area as well. So I go in with 2 hands, I lift up, I know where the tibial nerve is, I know where the perineal nerve is, and I'm going to be a little bit more dramatic with my pressure in this area. Yep. And I will always finish deep work, whether it's my press and stretch technique or my local technique to rid the patellar recesses of swelling. I will always finish with long strokes up the leg. Now, if you want to improve flexion, I highly recommend working the knee as best as we can. We're going to bend as far as we can possibly go with comfort. Right about here. We're going to support it. But here, if you look, you can see a lot of tension in the rectus femoris. And as the knee ages, they see that the rectus femoris tends to get fibrotic. And what that's going to do is it's going to make it even harder for the patella to move distally during knee flexion. So we're going to do a press and stretch of the rectus femoris, and at the same time, we're going to do an inferior glide of the patella. And the beautiful thing about this technique is it's now multidimensional. It's now three-dimensional. So we're press and stretching, we're working out dysfunction in the rectus femoris. We're pulling the patella inferiorly, and my little fingers in the suprapatellar recess are helping to break down any adhesions in that area. You okay? Good. And by doing this technique, we can actually beautifully gain more range of motion without really having to do an angular push on the knee. So just by those few little minutes that I just did, we're going to see if we can get any further in the bend. Yeah, a little bit right there. So we're going to get a little bit more here. Good. And again, try to get the soft tissue to release rather than cranking on the knee. Okay. And sometimes, you tell me how it feels, a little under the patella. So you're on the lateral side. So here and lateral. That's another fun thing to do with your patients, is every time you gain new range, ask the person where they feel it. They will always feel it somewhere new. And work through that again. You can feel the fibrous bands. You okay? Again, working, I'm avoiding an incision here, but I'm working through a tight fibrous band. Okay, let's say we do it 2 or 3 minutes. How's it feeling? Still feeling it? A little bit better? Okay, good. Then let's bend more. Good, and where do you feel it now? This time on the medial side. So what we're going to do, we are not going to angularly push this knee if we don't have to, and we're not going to do a translation on an ACL and meniscus repair. So what we have is we have the soft tissue. And what studies have shown is that in the first 2 weeks of immobilization, it is only the soft tissue that tightens. So if we can gain most of our range within the first 2 to 3 weeks of immobilization, then we have the greatest chance of getting where we want to go simply by press and stretching through tight myofascial structures. Okay, and it goes on like that as you're working with your patient.